I'm going to give it just a few minutes and let people log in for the next couple of minutes, and we'll get started shortly. And Erica, let me know if you can see people logging on. It looks like we're up to 191 folks logged on right at the moment. I'll give about another minute and we'll get started. So thanks to everybody for logging on. Going to get started here very shortly. So good evening, everyone. Thanks for joining us. Pleasure to have all of you join us this evening. I'm Dr. Dorothy Hitchmoth. I'm the treasurer of the Ocular Wellness and Nutrition Society and longtime board member. Our goal, as most of you know, is to bring worldwide evidence-based nutrition and wellness strategies to healthcare providers, scientists, and the public to help change the course of vision loss and poor health. We are passionate about saving sight and providing an unbiased representation of well-designed studies. OWNS is a 501c3 charitable nonprofit organization. And today we are privileged to welcome a distinguished speaker, Dr. Gerson, and he will be taking a deep dive into age-related macular degeneration. And I'm deeply honored to have him actually present today. Please, after or during the presentation, make sure you use the Q&A box for your questions. They will be addressed at the end of the session. Please also pay attention to the instructions at the end of the webinar so that you can receive your COPE certificate, which will come via email, and you will need to answer a survey question, as most of you know. And with any luck, my slides will advance. Maybe. Maybe not. Here we go. Before we get started, I also want to say that this activity is supported by an unrestricted educational grant from Notal Vision Monitoring Center. And we're going to hear from them before the webinar gets started. And you will hear from Megan Blemker in just a moment here. And Megan, I'm going to let you take it away for a few minutes, and then we'll get the webinar started.
Great. I'll just share my screen here. Well, good evening, everyone, and thank you so much for joining. My name is Dr. Megan Blemker. I am an optometrist by training and the Director of Clinical Affairs and Education at Notal Vision. And I am privileged to be here to speak to you all this evening and pleased to present digital remote monitoring proven for better AMD patient outcomes. Early diagnosis with good visual acuity is essential to preserving functional vision with anti-VEGF therapy, but unfortunately, only about 1/3 of eyes are diagnosed at 20/40 or better per the current standard of care. And as you can see here from the AAO Iris Registry real-world data, at the time of diagnosis of wet AMD until 2 years later, essentially where patients start with their vision is where they finish. So this is very important to catch them early with better vision. When you add F.A.A.O Home AMD monitoring program to the standard of care, this number or percentage of patients jumps up to 81% who maintain that functional vision of 20/40 or better at the time of wet AMD diagnosis. F.A.A.O Home works with proprietary technology called preferential hyperacuity perimetry, or PHP. There are a total of 500 data points that are tested 3 to 5 times each, and stimuli are presented on screen for 160 milliseconds, covering the central 14 degrees of the visual field. So who's a good candidate for F.A.A.O Home? Well, there are 2 qualifications, the first being a diagnosis of intermediate AMD, right eye, left eye, or both eyes, and a best corrected visual acuity of 20/60 or better. So once you identify an appropriate candidate for the service, the patient is referred to our Notal Vision Monitoring Center, where our team of certified ophthalmic professionals takes care of patient financial services, device shipping, education, training, compliance monitoring, and alert notification. So after the patient starts monitoring and they've established a baseline or their starting point, if over time there is a change in their metamorphopsia, a statistically significant change, the system will alert you, the referring doctor, and then you can make the decision to bring in the patient for examination to determine if they have converted to wet AMD. So once the patient comes into the office, if there is no exudation detected, then you can keep the patient in your practice. There is a predictive value with these alerts, these non-exudative alerts, showing that patients are at higher risk of conversion. But we would ask the patient then to reestablish a baseline, and then they would stay under the care of the optometrist who maintains a long-term relationship for their disease management. If, on the other hand, when there is a statistically significant change in the metamorphopsia from F.A.A.O Home, that alert that is sent to the referring physician brings the patient in and sees that the patient has converted to wet AMD, that diagnosis there, then on average, patients with F.A.A.O Home are at 20/39, so a dramatic improvement from what we saw with current standard of care alone. At that point of time, then the referral is made to our retina colleagues where treatment can begin, and that's where that early treatment is the best predictor of better long-term visual outcomes. And our patients deserve better vision outcomes and quality of life. So putting it all together with the current standard of care, most patients, intermediate dry AMD, if they start with a baseline visual acuity of 20/25, unfortunately, they'll go months, according to studies, with undetected vision loss with this current standard of care. And even after treatment initiation, their vision does continue to decline, over the years. If you add F.A.A.O Home to the standard of care, then the average visual acuity at treatment initiation is around 20/39, and then they have a much better visual quality of life, with 84% of patients maintaining that 20/40 or better for years after treatment initiation. So we invite you to join our network of F.A.A.O Home providers, over 3,000 referring physicians, and over 8,000 actively testing patients. We seek to partner with our optometric community to manage these patients confidently, detect wet AMD earlier, and retain the intermediate AMD patients in your practice until the point of referral. And this is all at no cost to your practice. If you would like more information, I've got my email address here, or you can visit our website at f4chome.com. But I thank you very much, and I also look very much forward to listening to and learning from Dr. Gerson this evening. So thanks for having me. Thank you, Dr. Hitchmoth.
Yes, thank you. Thank you for that introduction. We love Home F.A.A.O. F.A.A.O Home. I keep always messing that up. It's a big joke now. So just want to, again, welcome everybody. I can see that a number of people have joined since we started our introductions. And thank you to Notal for being the education sponsor tonight. I'd like to also remember everyone that the Ocular Nutrition and Wellness Society, as I mentioned before, is a nonprofit education organization. Our growth is sustained through contributions from members, donors, industry supporters, sponsors, and volunteers. And we have a number of member benefits. Your membership actually contributes to the momentum that drives our education initiatives within the rather dynamic and evolving realm of nutrition and lifestyle medicine in eye care and beyond. Some recent membership benefits include the doctor lookup feature, where you can connect with patients and colleagues who are passionate about lifestyle medicine. We have an ongoing collaboration with the American Nutrition Association, and many of our graduates are already applying their knowledge in whole body nutrition thanks to this partnership. And don't forget that OWNS members receive the highest tier discounts in this program. And you want to make sure before that you sign up before the end of this year, because that that discount will end. So just a few of our member benefits. And as I stated before, this educational webinar is thanks to Notal Vision Unrestricted Education Grant. And it is now my pleasure to introduce Dr. Jeff Gerson, our speaker tonight, and the person you've all been waiting for. Dr. Gerson graduated from Indiana University School of Optometry in 1997, went on to do a VA residency in low vision and ocular disease. He's been in several different practice settings, including a retinal referral practice where he participated in several large clinical trials. He's currently in private practice that is in collaboration between both ODs and MDs. He sees primary care patients and has an emphasis on retinal care in his practice. He also is a preceptor for fourth year optometry students and participates in an ongoing fashion in clinical trials and utilizes many different diagnostic modalities. He is a frequent lecturer in the US and abroad and writes regularly for optometric publications. When not at work, he obviously enjoys traveling, working out, spending time with his family. And I will tell you, I know Dr. Gerson personally. He is an optometry rock star, and I expect this webinar to be amazing tonight. So stay on, stay tuned. Don't forget to put your questions in the chat box, and I'm going to hand it over to Dr. Gerson.
Thank you, Dorothy. It's almost not fair, by the way, to have an introduction like that. I mean, you're setting the bar pretty high.
Sorry.
Yeah. So, man, I guess I have no choice but to perform here. So first and foremost, I just want to thank everyone for attending tonight and being here. I know, especially for those of you on the East Coast, it's kind of late. So I appreciate you staying up for this a little bit later in the evening than what you normally would. When I was first asked to put this talk together, I decided I was going to kind of look at things and do this from a little bit different spin. I generally don't like just doing a very plain talk. And if you've ever been to one of my talks when it's in person, I always involve the audience. I'll try to ask questions and try to get people involved. And the reason for that is I think it makes it a lot more interesting. And so hopefully I can ask some questions and we can make this interesting as we're going along. And you can comment in the chat section if you'd like, or send in questions in the Q&A. I'll be monitoring both of those as we're going along. So actually, I should go back a slide real quick and just say, so just to kind of point out the title, AMD Chartering a Better Patient Experience. So that's kind of the spin that I'm going to put on this. This is not just going to be about what's the best injection, when do you send your patients for an injection, and why. Because we've all heard that, right? We've all heard that 100 times. And we know that if someone has wet AMD, you send them for injections. We also know now that if your patient has geographic atrophy, you send them for injections. But we don't do those injections. So what I'd rather spend my time concentrating and talking about are the things that we can do for our patients, that we can do to charter a better experience for them and better quality of life. So quick disclosure, I've been involved with a number of different industry companies. All relevant relationships have been mitigated. I don't know what that statement means, but I've been told it's supposed to be on your disclosure slide. So if anybody knows what that means, feel free to reach out to me and let me know, because I say it every time I do a talk and I have no idea what it means. All right. So I generally like to start my talks with a conclusion, because Dorothy said, hey, everyone should stay tuned for the next, hour and 40 minutes. But I know that an hour and 40 minutes from now, we will have lost some of you. So I always start with a conclusion. The conclusion when it comes to AMD is that prevention and early detection are the keys to ultimate patient success, and that treatment of advanced AMD is not good in the long term. So Megan even showed us studies that show what happened, especially if people are diagnosed with wet and their vision's already decreased. It sort of stabilizes, but over time, it gets worse. And so our colleagues, retina specialists, we refer for treatment of wet AMD. They've got a tough job. Our job, although maybe tougher as far as early detection and prevention, may be tougher, it's likely to be way more rewarding. So between the two, I would say we've got the better job. So another important conclusion, as we move forward, if we were to look into a crystal ball 10, 15 years, there will be more patients just because of the aging demographics of our country, more people with AMD, and there will be less MDs to see them. So interestingly, I was at AOA optometry's meeting last week, and I was at the I'm going to call it the wrong thing, just like Dorothy butchered the name of 4C Home, but I was at the Student Bowl. I think it's called the Student Bowl. And when all the students were coming up, I think there were like 24 schools. And not to date myself, but when I went to optometry school, I think there were 16. And the point is that in optometry, we keep producing more and more optometrists. However, ophthalmology is not doing that. There are less ophthalmologists finishing training today than there are retiring. So more of the burden for this type of disease care is going to fall on us as optometrists. So that means we need to be more comfortable spending time diagnosing, more importantly, discussing AMD with our patients, educating appropriately, being more proactive, and helping our patients have better outcomes. So simply put, or asked, why do we need to discuss AMD? So there's almost 300 of you on here. So obviously you all thought it was important to hear a little bit about AMD tonight. Well, why do we need to do that? Well, if we look at just some prevalence numbers and we see how much AMD there is compared to glaucoma or diabetic retinopathy, we see that there's more AMD than both of those combined in the US. We see that if people are over age 75, about 1 in 3 have macular degeneration. So depending on the demographics of your practice, AMD should be something that you see on a daily basis, whether you realize it or not. And I'll go over some statistics that show us that sometimes we're seeing AMD patients and we just don't realize it. And so step one is going to be, we have to realize it. Step two is then to do something about it. And oddly enough, I'm not sure which one of those is more difficult to actually pay the time and attention to detect, or once you do, to step forward, have a conversation, and do something about it. Both are things that we're charged with doing. Neither one is necessarily easy. Now, just a minute ago, I said that, if you're over 75, 1 in 3 have AMD, whether you realize it or not. This was an interesting study that was published about 7 years ago. And so Dorothy mentioned the importance of science-based medicine or evidence-based medicine. And I wholeheartedly agree. And it's really the way that I practice optometry, is really trying to have science-based, evidence-based medicine be kind of the foundation, the bedrock of what I do. Now, I think there's other things that come into play other than the large randomized controlled clinical trials, but I think those are always going to be the foundation. So anyways, in this study that was done about 7 years ago, the study committee went out to eye doctors, ODs and MDs, and they said, we want you to examine patients over a certain age, and all you need to do is tell us, do they have AMD, yes or no? Then what we want you to do is take a picture, send us the picture. We're going to grade you. So all you got to do is one thing, and we're looking over your shoulder. If somebody tells me those two things, I'm going to try pretty hard. Well, as it turns out, about a quarter of the time when the doctor said there was no AMD, there actually was. And not only was there AMD, but 30% of the time there were large drusen, something that we should never miss. Yet very oftentimes it was completely missed. So a little bit of good news, a little bit more of bad news. The bad news here is, in general, eye care does a lousy job of identifying AMD, even if it's the only thing you're looking for. Now, the good news, this isn't really good news, I say this a little bit tongue-in-cheek, is that both optometry and ophthalmology did a lousy job. So this is not an optometric problem. This is not an ophthalmology problem. This is an eye care problem. That even if it's all we're looking for, which is not a real life situation, we miss macular degeneration. And if we miss it, then we can't do something about it. So let me ask you another question. And again, feel free to type something in the chat. That's how I know that you can still hear me and somebody out there is awake. When I say AMD, what's the first thing you think of? So is it wet versus dry? Is it that they need intravitreal injections? Is it, if I have that patient, do I need to refer? So if we're just playing a word association and I say macular degeneration, what comes to your mind? So I've got drusen, I've got smokers, dry. So interestingly, yeah, hopefully it's dry and what we see are drusen, but we know that many, many people with AMD are smokers. So we're getting a good cross section of things that people think of. And I think that's representative of how we think. There's a whole bunch of different things that we think of. Now, by the way, virtually everything that people are putting in here is a clinical finding. There's only one or two that weren't clinical findings. Okay, so what about this? So here on the left, we have drusen. On the right, we have a wet AMD. Do you think about what it means for somebody's vision? Do you think about how it changes a person's outlook on life? What does it really mean? And I think more importantly, it shouldn't be what does it mean to you? More importantly, when we're thinking about our patient's experience and their journey, what does it mean to them? And so if we think of AMD like this, then maybe, just maybe, it will change your outlook at least a little bit. And you'll think about it from a purely patient perspective and not just a clinical finding perspective. Because your patients don't really care about clinical findings. What your patients care about is what's my vision and what's my vision going to be. And I'll share with you some of the wording that I use and some phrases that seem to work for me with my patients. But I look at AMD from this perspective. And what I always tell my patients is I never want to be the cause of undue anxiety. Now, if there needs to be anxiety or if there's truly an urgent issue, they need to know that. But if there's something that's very low risk, then I need to make sure I'm educating appropriately and not creating anxiety that does not need to be there. But I just challenge you with your next AMD patient, whether it's tomorrow or the next day or whatever day, think of it like this. Think of it as far as what does it mean to my patient's vision and their journey, other than just, well, what does it mean to my day and am I going to get behind? Because what we know from publications is in general, we dramatically underestimate the impact of AMD on a person's quality of life. And so we just have some statistics here. And so even very mild AMD, where someone's vision is probably 20/20, maybe just a little bit of an issue with dark adaptation, but probably still 20/20, they are already, sorry about that, they're already having as much decrease in their quality of life as somebody with moderate cardiac angina or somebody with HIV. That's eye-opening to me. The same study showed that we underestimate the amount of impairment on our patients' quality of life up to almost 1/8, meaning our patients will say that the amount that their quality of life is decreased by AMD is almost 8 times as much as what we would think. We very rarely assume that it has a greater effect on their quality of life than what our patients would say. So again, I'm challenging you to think about AMD a little bit differently, not just about the shots, the treatments, the supplements, but what does it really mean? Okay, so what should our first thought really be? And I guess that's a little bit open to interpretation, right? Is it patient-centered? Is it clinic or treatment-based? And I guess it kind of depends on what stage they're at, right? If somebody presents to your office, new patient, and they have wet AMD and a decrease in vision, well, that's pretty obvious that the first priority really needs to be, I need to get this person referred for treatment. Now, if it's somebody with very minimal AMD changes, it's a completely different story. And our first thought needs to be different. I think the first thought needs to be, how am I going to appropriately educate this patient so they know the different lifestyle modifications they can make, that they know they're relatively low risk in the short term, and that I'll take care of them in the long term. So two very divergent tracks depending on kind of where we're at. But ultimately, our first thought should be directed towards the patient and the patient experience. So again, if they come in day one and it's wet, the most important thing for their ultimate experience is get it treated as soon as possible. If they're 20/20 and it's mild, well, we don't need to send them for treatment. We need to educate them. We need to not create undue anxiety. It's very different, but either way, it's patient focused. Now, before you get too worried about me just talking about all this kind of woo-woo stuff, I will tell you that, of course, I will discuss AMD from the doctor's perspective, what we need to know, what our patients already or need to know, what are the steps along the experience or journey for our patients, and sometimes for us, how we can discuss AMD. So when I say treatment options, I think it's really important that when we as optometrists think about treatment options, that we're not just thinking about injections or even an AREDS2 formula, because both of those stages are frankly too late. I think we need to be thinking about nutritional options, so foods, supplementation, and lifestyle changes that can have impact on our patients, both from an eye perspective, but also a global overall health perspective. Now, by the way, I could talk about each of these subjects for an hour easily, and we could have interesting dialogue about these for at least an hour. So although not rapid fire, this will be more of kind of a survey course of these different topics. So I won't dive too deep into any of these, but deep enough. So I think we'll all have kind of a general idea of some of the things we can and should be doing. So let's start with the case. So I remember the first time this patient came in. He was an 80-year-old, really stubborn guy, a immigrant from Russia. Both eyes look the same. His vision is 20/25 minus in both eyes. His chief complaint is my vision is smeary. My vision is smeary. So just knowing that, what do you think? What are you going to pay attention to? What's next? So I'm monitoring the chat here. So feel free to put something in the chat. And while you're typing, I'll tell you, by the way, just ignore his optic nerve because we're talking about AMD tonight, and he does have fixation threatened, really bad glaucoma. But the glaucoma wasn't causing his smeary vision. Neither were his cataracts. That might have been part of his smeary vision. But I think a big part of his smeary vision was the changes in his macula. So this is somebody that has pretty obvious intermediate dry AMD. So this is someone that I would start on an ARH2 supplement. He was a smoker at the time, so that was something that, of course, we would want to talk about. And this is somebody that I would start on 4C Home because he is a intermediate dry AMD patient with good enough vision to do so. And so, yeah, the question is the vision decrease due to macula or cataracts? And truth be told, is probably at least some of both. And so we should address both, whether it be through some treatment or at the very least education. So let's look at AMD from a different perspective, a different patient. This is a 68-year-old with type 2 diabetes presenting for a routine exam because their primary care doctor said, you need to go get an eye exam because I don't get paid as much by Medicare if you don't get an eye exam. They probably didn't say that exactly, but that's part of the truth. Patient says, I have no real complaints, but I don't like driving at night. They're 20/20, no family history. And for us, the easy button when someone says, I don't like to drive at night is, you know what? At age 68, it's normal not to see as well as what you used to. And I think that's just patently false. If somebody doesn't see well, there's a reason for it. Age alone, a number, never causes vision loss. I had a patient today she's a spry 91-year-old, and she has 20/20 vision. She sees great, and she's 91. Someone that's younger could have vision problems. If a patient tries to use age as an excuse, what I let them know is, because of your age, you may be more likely to have an age-related eye condition. Age alone doesn't cause vision loss. So let's figure out what, if any, age-related eye condition you have so we can uncover the reason and ideally do something about it. Now, what if I told you this person failed a dark adaptation screening test? Well, to me, that means this person has macular degeneration that I'm going to address through education and lifestyle factors. Yeah, so a comment, smeary vision could also be poor tear film. There's a lot of reasons, right? And I think the important thing here is not to get distracted by any one of them and potentially to find all of them. So when you're back in your office tomorrow, when you do your clinical exam, what's the minimum findings for you to have a patient qualify for having age-related macular degeneration? So this is kind of an easy one to go ahead and type something in the chat. What will it take for you to tell someone that they have macular degeneration? Now, by the way, I think AMD is something that patients deserve to know about, and it's important they know about. And I wouldn't necessarily say I enjoy telling them about it, but I enjoy telling people about very early AMD because their vision's good and there's things we can do to keep it good. I particularly don't enjoy telling people that they have new wet AMD. That's no fun. So I have poor dark adaptation. Yep. So that is diagnostic. Multiple drusen. As long as the drusen aren't what are called druplets. Druplets are tiny drusen that are less than 63 microns in size. And that could just be a normal age-related change. The other big one is age-related pigmentary changes. And then the other one that is not a sign or not needed to have AMD is decrease in vision. Believe it or not, someone can have wet AMD, need injections, and have 20/20 vision. Totally possible, right? That's the best person to have wet AMD. their vision's still 20/20, get it treated, they can end up with good vision. All right. So let me ask you, what is pre-AMD? Well, what I'll tell you is pre-AMD is just something that I made up. But the reason I made it up is because there's a well-defined term, prediabetes. And prediabetes basically means if you don't do something, you're going to likely get diabetes fairly soon. So we do something if someone has prediabetes to try to prevent the onset of overt diabetes. And I would contend that we probably need to be doing the exact same thing for our patients that have pre-AMD. So what is pre-AMD? Well, for me, it's people that are at much higher risk. So maybe someone that has a family history, poor diet, they're a smoker, they're obese. Maybe they have some generalized thinning on OCT in their macula, but no drusen, and it's not AMD yet because they have normal dark adaptation. But these are people that we need to watch more closely because they are more likely over a relatively short period of time to develop macular degeneration. Okay, so how and where does AMD actually start? Well, the easy button there is AMD starts in the macula. Duh, right? It's in the name. Well, what we need to realize is that the disease process of AMD starts below the surface. It's there before we realize it's there. So here's just kind of a schematic of a normal retina where we see choroid, RPE, or choroid Brooks membrane, RPE photoreceptors. And everything looks normal. Here's a patient that technically has the earliest stage of macular degeneration. It's subclinical, meaning you're not going to see this clinically, but the AMD has started because of those basal laminar and basal linear deposits along Brooks membrane, only detectable through dark adaptation, but clinical exam and OCT won't show you anything. Just because you don't see it, does that mean it's not there? Absolutely not. It's there. And then that gets a little bit worse, but you still may not see it until our patient has obvious drusen. And what we know is this subclinical AMD sometimes exists for at least 3 years from clinical trials before we see any actual clinical changes. So if it was you, wouldn't you want to know 3 years earlier so you could start paying more attention to your lifestyle, to your diet, or any of the other risk factors that you're going to want to be paying attention to? So one of the things that I do in my office is dark adaptation testing. It's kind of like glaucoma and glaucoma testing. So, if you have a patient that has preparametric glaucoma or even fairly early glaucoma before it's fixation threatened, would you do something about it? And I think all of us would say, well, yeah, of course we would. Well, then let's ask the same question when it comes to macular degeneration. If somebody has macular degeneration before it's clinically overly obvious or having a meaningful effect on their vision, should we do something about it or should we wait? Again, I would contend that we don't wait. We do something about it. These are my favorite patients to tell about AMD. And here's why. I'll share with you some of the ARIDS and ARIDS 2 data and the ARIDS simplified scale. And one of the things we know from the simplified scale, and I'll get to it to explain it in more detail, but if someone has 0 points, and you'll know what that means in a few minutes, the likelihood of them having wet AMD in 5 years is about 0. And so what I tell all my subclinical AMD patients is this is really good news that we found this because we're going to start doing something about it. And here's the 5 things we're going to do. And by the way, the likelihood of you getting into trouble over the next 5 years is about 0%. I then say, but I'm not worried about 5 years. I'm worried about 15 or 20. And that's why I don't want to just say, well, 5 years, we're in good shape. I want to do what we can to make sure you're going to be okay in 15 or 20. So subclinical AMD is AMD, and I think is something that needs to be treated appropriately. So there's a question, why do dark adaptation prior to OCT, OCTA? And really the simple answer is you will find AMD through dark adaptation years before you'll find it on OCT. There's another question, how do you follow your failed dark adaptation tests in patients with very little other signs or symptoms? Well, I let them know they have macular degeneration. We're going to treat it accordingly. And if there's no real clinical signs, it's just an impaired dark adaptation, I generally have them back and do retesting once a year. So that's how I would follow that patient. Good questions. All right. So traditionally, we think of AMD as far as the scale of the classification scale, the Beckman classification scale as being this. No AMD, early, intermediate, and advanced. Advanced being either GA or wet, But the reality is we have another stage within a true classification scale, and that would be subclinical macular degeneration. And those are people that have either no drusen or just small drusen less than 63 microns, no pigmentary changes, and impaired dark adaptation. So by the way, if you're wondering how accurate, if I'm putting in so many eggs in this basket, how accurate is dark adaptation testing for macular degeneration? It is 90% sensitive and 90% specific. There's a question, can you track improvements on dark adaptation results? If there were improvements, you could, but theoretically there should not be, because in order to get improvements in dark adaptation, you have to clear the deposits that are building up along Bruch's membrane. And we don't yet have a way that we know we can do that through diet or medication. Question, so what supplement do you put them on if I fail dark adaptation and subclinical AMD? So, in the words of Nike, I would tell you just do it. And so what I would tell any colleague is a carotenoid-based supplement. I wouldn't use AREDS2, I think that's overkill, but a carotenoid-based supplement is what I would do for any of my patients with subclinical AMD. And to be quite honest, what I do is I ask them, are you someone that wants to buy your supplements in a store, or would you like me to have them sent to you? And so to me, more important than which one is figuring out where our patients at and what they're going to be willing to do and have some compliance with. Is this all self-pay? When I do a screening test, it is. But once they fail and I do the extended test, which is akin to doing a threshold visual field, it is paid for by insurance. And it pays about the same as doing a visual field. All right. For dark adaptation, I'm using the AdaptDX Pro. Would vitamin A be a good recommendation for these subclinical patients? Not really, because it's not that they're not getting enough vitamin A. It's that it's not able, because of the deposits, to pass through into the macula. So think of a screen that's all clogged. So if you have a nice screen that's clean and the wind is blowing, you get a nice breeze in your house. But if you clog up the screen, it almost doesn't matter how hard the wind blows, you're not going to get a good draft in the house. So this is kind of showing what happens, that when you get deposits along Bruch's membrane, you have impaired metabolic transport in and out of the retina and out of the macula. So again, it's a clogged screen. So you can only push so much through a clogged screen. So I apologize. My slide, when I transferred it from another talk, it cut out a couple of the words, but what this is showing is that if you compare dark adaptation testing to any other test you use for sensitivity and macular degeneration, that it's far superior. It is way better, both in sensitivity and specificity, than visual acuity, contrast, color, visual field, any other subjective test you can do. It's like doing a stress test, or like having a cardiologist do a stress test. It finds problems much sooner. So there's a question, did you mean you never see improvement and the best we can expect is to slow down the process? I've seen drusen disappear. That's an interesting question. Drusen can change. Drusen can collapse. And as it turns out, collapsing drusen is a risk factor for geographic atrophy. So I would just warn you not to be fooled that disappearing drusen is always a good thing. There was actually a study several decades ago that showed that with laser, you can actually get drusen to disappear some. However, when that happens, you increase the risk of wet AMD. So disappearing drusen is not actually necessarily a good thing. What about saffron? So saffron and some of the other spices that are used primarily in other parts of the world are incredible antioxidants that I think are vastly underused here just because of our diet in general. So my experience with dark adaptation is that it helps me to see just how prevalent dark AMD is. So I did an IRB approved study where I took 100 consecutive patients. There were 16 above that had a normal appearance to their macula, had a normal OCT. 39 out of 100 failed dark adaptation. So that means 39 out of 100 normal patients have macular degeneration. That was startling to me. So what we need to know is that dark adaptation is likely the first unrealized symptom of AMD, and that's even in the American Academy of Ophthalmology's practice guidelines for macular degeneration. And so it's something I do on everyone over 60. And so kind of my routine of what I tell people to do as far as preventing any further changes is I tell them 5 things. I say, I'm going to have you start doing 5 things. The first 4 are going to sound awfully familiar compared to what you hear from all the other doctors. And those are, and I smell and either say, consider quitting smoking or don't start smoking. I look and either say, try to lose a few pounds or don't become obese. Try to have a diet with more green leafy vegetables, less refined carbohydrates, which are probably just as important as the green leafy vegetables. And try to be active. And what I specifically say when I say try to be active is you don't need to run marathons or pump iron, just do something. I then follow that with, so have you heard something similar to that from any of your other doctors? Everyone says yes. So then I say, and then the one thing I'm going to do a little differently is I want you to take a vitamin specific for your eyes, for macular degeneration. And then I make a very specific recommendation for their vitamin. I don't wait for it to get worse. So again, we have the historic stages of macular degeneration, early, intermediate, and advanced. Advanced is usually wet, and about 20% of the time when it's advanced, it's actually geographic atrophy. I already shared this with you, a more comprehensive disease classification than the last slide, including subclinical AMD, because I would tell you that arguably this is the most important stage at which we can interact with our AMD patients. The reason for that is once somebody gets to advanced, it's just a matter of time until they're not going to do well. If we intervene when it's subclinical, when it's super early, I think that that gives us the best opportunity to save as much vision as possible. All right. So earlier I mentioned the AREDS simple scale, and I really like this. So, so actually there's a comment that failing or reduced dark adaptation leads to a diagnosis of acquired night blindness. OCT leads to a diagnosis of ARMD. So how is dark adaptation better than OCT-OCTA? Well, the simple reason is it finds it earlier. And if someone has impaired dark adaptation, it's 90% likely that it is macular degeneration. If you have what looks like drusen on an OCT, well, you also need to do your clinical exam and put everything else together. It may or may not actually be macular degeneration. But so OCT and OCTA are great. They're not going to find macular degeneration quite as early in the process as would dark adaptation. There's a question whether I do genetic testing. You know, I kind of go back and forth on whether I do genetic testing, and I'm going to get to that a little bit later. But I think it's absolutely a valuable thing to add on because of what it can provide for your patients. Specific recommendations regarding supplement. You know, that's something that any of us could engage in an hour-long conversation, which we're not going to do. Again, I think the most important thing is start supplements early, carotenoid-based. I think do your research, find a company that has something that's science-based, and get them started on that. Do I provide patients with a handout? What I generally do is I send them to a website, Macular Degeneration Association, macularhope.org, and there's a lot of great information there. So a lot of times that's what I will do. So here you have the AREDS simple scale. And so this is a game where you earn points. And this game is like golf, not bowling. You want a low score. So you get 1 point for any large drusen in each eye, 1 point for any pigmentary changes in either eye. So the score is 0 to 4. And what AREDS taught us is if you have 0 points, your risk at 5 years is well under 1% of having wet AMD. That's why these are my favorite patients, because I can tell them that there's virtually 0% chance that you're going to have a problem within the next 5 years. If they have 4 points, then it's approaching a 50% risk. Now, there was an updated version of this that was just published online just within the last month or so. And this was part of the AREDS study, report number 42. And it includes looking for reticular pseudodrusen as another thing that portends risk. And so you can see here that if somebody has reticular pseudodrusen, it dramatically, so at least double in each category, except for if you have 4 points. But all the rest, it dramatically increases your risk of converting to wet AMD over 5 years. So that is a very significant finding, regardless of looking at drusen. All right. What different methods for measuring dark adaptation have been compared? Well, the good and bad news is there's really only one commercially available device. The good news is at least there is one. The bad news is there is only one that's validated and really has been shown to work. Okay, so let's go over a couple of things that are new in AMD. So we've all heard about the treatments for geographic atrophy. And when the anti-VEGF treatments first came out, we saw all these complicated charts and what VEGF is and anti-VEGF and this whole tree of where everything is. And it was pretty complicated. And really all that we needed to know was if someone has wet, these drugs work. And so what I would tell you is there's that same very complicated tree of pathways for geographic atrophy and the complement system. What we need to realize is there are two FDA approved drugs. One works at the level of C3. The other one works at the level of C5. They both work on the complement system. So they're very similar medications to each other, but they really are a little bit different in how they work and even a little bit in what the results are. Okay. So as I said, there are now two approved treatments for GA, Syfovre and Izervay. And this has created a whole new conversation and paradigm shift. Patients know about this and are asking. Do you know why patients are asking about geographic atrophy? The real reason why people are asking about geographic atrophy, excuse me, is because they're seeing things on TV by the Fonz, by Henry Winkler, talking about geographic atrophy. So that gets people's attention. So the Fonz is helping to create awareness. And so seniors are therefore painting on their faces. No, they're not. But on the bottom right, it's a still shot from the commercial for Syfovre, where, don't ask me why in this commercial, it's a bunch of senior citizens that have painted tropical looking animals in tropical colors on their face. It catches people's attention. I'm not sure it says anything about macular degeneration, but it catches people's attention. Now, what's important to know about both these drugs is they do not stop the progression of GA, but they've been shown that they can slow it down. What they've also shown is efficacy seems to increase over time, that the longer someone is on one of these medications, the more of a divergence there is between control and treatment. So that's something that's new and exciting. What about treatment for wet AMD? Well, we all know about the medications for wet AMD and that they're intravitreal injections and that none of us are doing, at least as optometrists, none of us are doing intravitreal injections. The main differences today from 10 years ago aren't in efficacy. They all work basically the same as when we had Lucentis 10 years ago and it was being injected monthly. The difference is in the efficiency, or more appropriately said, patient burden. So again, if we go back to how does this affect our patients? It's easy enough to say getting an injection isn't so bad because most people would agree it's not. But what's so bad is needing an injection every month. That's much worse than needing an injection every 2 months, 3 months, 4 months. So Dr. Hitchmoth and I were talking before this started, and she was saying for her to send a patient to a retina specialist, they may need to go 100 miles, 200 miles. Now, I'm lucky where I live is if they go 5 miles, they can see somebody. But think about the burden on patients if they're elderly, they need someone to drive them, and they need to get treated once a month. And what's the difference between that and every 3 or 4 months? It is a huge difference. So another, I have in quotes, new approval because it's really not new anymore, is Vabysmo by Genentech. So this was the first bispecific module. So it's anti-angiopoietin 2 and anti-VEGF. And for macular degeneration, about half of study participants went 16 weeks in between injection. And what they found was vision and thickness was equivalent to monthly injections of other medications. Now, by the way, the picture here is from the, again, a still shot from the TV commercial for this drug. So, you know, when I watch a little bit of TV this afternoon, if I think about the commercials that I saw on TV over the last 24 hours, I saw one for this, I saw one for Eylea, I saw one for Syfovre, I saw one for Xiidra, I saw for thyroid eye disease, disease state, I found one for the medication, saw one for the medication for thyroid eye disease. That's 6 very different direct-to-consumer messages that I saw on TV within the last 24 hours. Now, maybe what that means is I'm watching old people TV. I don't know. But these companies are doing direct-to-consumer marketing. Another new approval is aflibercept 8 milligrams. That's Eylea. Previously, it was approved at a 2 milligram dose. And what they're able to show is that, again, the vast majority of people can go at least 12 weeks. 79% can go 12 weeks. 77% can go 16 weeks, and over 80% can maintain at greater than 12-week intervals. That's a big deal. So the vast majority of people are going at least 12 weeks, 3 months. So you're decreasing the overall burden on patients by a third. Oh, and Dorothy's telling me she's watching the same old people TV. I'm not sure that that's comforting. You should have said something like, it's not old people TV, but thanks anyways. And not a major drug or drug company, but this is something that I recently read and thought it was interesting. So this is something that was just published about 2 weeks ago. And it was about melatonin supplementation and macular degeneration. And it showed that melatonin use was associated with both a decreased risk of developing AMD and associated with a statistically significant decrease in risk of progression of dry AMD to wet AMD. And there was also a study that corroborated this that was published in China about 15 years ago. And in that study, they specifically took 3 milligrams of melatonin daily, and it decreased the conversion to wet. Is this going to change the way we do things? I don't know, but I like reading about this stuff and kind of having it filed in my head, because sometimes patients ask about things, right? What else could I possibly do? And I can tell them, well, there's this article that was recently published about taking melatonin, could potentially be beneficial. Have you ever thought about taking melatonin? So I like looking for alternative treatments. And I actually don't like that word, alternative treatments, because to me, that has kind of a negative connotation. I think these are just additional treatment options. They're not really alternative. If anything, things like this should be the mainstream. The mainstream shouldn't be wait till you need an injection and get that. Mainstream should be, how can we be preventative? And by the way, if you look at the risk ratio here and how statistically significant melatonin was in the 3 different age groups, and over 50, over 60, over 70, you'll see that those numbers are amazing, that it's tremendously better than the control. Interesting. All right, let's talk a little bit lifestyle. All right. Oh, can't believe that I didn't end up watching the ubiquitous Jardiance commercial. I think I did, but I just toned that out. Jardiance and Ozempic, I see it all the time, the people singing and dancing and doing whatever they're doing. My wife sometimes has asked me several times when we see these commercials, she's like, why are they just showing people doing nothing? Well, it's because the drug companies have to tell you all the potential side effects. And while they're doing that, they can't talk or show other words on the screen. So they just show people doing happy things when they're telling you that the drugs may kill you, give you diarrhea, or cause negative side effects. What's the annual cost to Medicare of the anti-VEGF treatments? The simple answer is more than any other drugs cost Medicare. Anti-VEGF treatments are incredibly, incredibly expensive. Okay, so when we start talking about lifestyle, I think one of the most important things we could talk about is food. And Hippocrates said, let food be thy medicine. And unfortunately, many of the patients that we're dealing with today fall into this genus and species: Maximus, diabeticus, triglyceritis, hypertensus. And so many of our patients look like this. It's not just because of food. Let's be clear. It's because of lifestyle in general, of which diet plays a major, major part. But obviously, there's other things that play into it as well. So a quick tribute to 2 of my good friends and mentors who had passed away a number of years ago. The first one is to Stuart Richer. And Stuart Richer was absolutely passionate about nutrition. And not only was he passionate about the need for better nutrition and supplements and using this as a means to treat people, he was also passionate about making it accessible, because he worked at a VA and he needed things that could be beneficial, but not overly costly. So Stuart would talk about canned spinach and sardines. Now, the downside is most people don't like either of those. But if someone does like canned spinach and or sardines, they are really inexpensive options to get tremendous nutritional benefit. So I wanted to point that out. Not everything that we should talk about when it comes to nutrition is something fancy. I had a patient just last week say, it's too bad it's so expensive to eat healthy. Now, I get it. Canned spinach is nowhere near as good as fresh spinach. I get that. But canned spinach is probably better than no spinach. All right. So the other mentor I wanted to mention was Larry Alexander. And Larry taught me that an egg a day keeps anti-VEGF away. So here you see a number of studies that show that just eating an egg a day can decrease the odds of developing wet AMD. It can increase serum lutein and zeaxanthin. It can improve macular pigment. Why do I like this? Well, I like this because what I'm always looking for my patients are simple solutions. If everything we talk about is difficult and it takes a circuitous path, that's a good word, right? A circuitous path to get there, then good luck getting your patients to do it. If you say, look, if you can eat canned spinach, sardines, and have an egg a day, you're going to be a world in a better place than where you are now. There you go. So I love talking about very, very simple means of discussing nutrition and lifestyle. It's got to be easy. It's got to be easy. Someone was mentioning big box of organic spinach leaf salad at Costco is less than $5. It's enough for a week's worth of lutein. All right. And should we think twice before sending someone with dry AMD for cataract surgery, considering the post-op inflammation and risk to the macula? So it's been more than 5 years. It's maybe been close to 10 years since the last, I would say, somewhat definitive study on this. And it showed that actually having cataract surgery compared to not does not increase the risk of progression to wet AMD. In the study I'm thinking of, it actually showed a decreased risk. Why that is, I don't know. Is that real? I don't know. But it certainly did not show an increased risk. But to your point, the worst thing is to send someone for cataract surgery. They're seeing great, and 2 months later, they can't see because they developed wet AMD. Okay. Here's why we need to discuss nutrition. And I know I'm probably preaching to the choir when I talk to this group, but let's do it anyways. What is the leading source of antioxidants in the average American's diet? Let's have you put the answer in chat. Now, I don't have a prize to give out, but we can pretend. Yes, Scott, you are right. It is coffee. We have several people answering coffee. That is correct. What percentage of Americans follow the 4 healthy lifestyle habits of routinely exercising, not being overweight, not smoking, and eating enough fruits and vegetables? Jeff, 0. I see 25, 10, 12. It depends on the study, but it's generally around 4 or 5%. So Adelina, you are correct. What percentage of vegetable intake in the US is potato plus ketchup? It's more than 50%. And so most of that is French fries. The leading fruit in the United States is orange juice, and the leading vegetable is potato. 15% of tomato consumption is ketchup. But think about that for a second. The leading fruit is orange juice. Is that good or bad? Does anybody have a thought on that? Having orange juice being the leading source of fruit, I'll say fruit matter, is that a good thing or a bad thing? No bueno, terrible, sugar without fiber. Yeah, so yep, you guys are all on course. Let me tell you just how bad it is. So how bad is it? So, oh boy, it looks like the slide got hidden. Let me see if it still got hidden here. Yeah, it got hidden. The slide that got hidden was that for people that have 1 serving of fruit juice a day, they increase their risk of developing macular degeneration 21 times. That's not 21%. That's 2,100%. Isn't that amazing? So fruit juice, someone said no bueno. That's probably the best way that I could put it. It is no bueno. All right, when does it become important to discuss nutrition? And what I would argue is everyone should pay attention to it. It should be both preventative and treatment. Excuse me. So what I mean for preventative is before there's overt disease, even subclinical. We should be talking about general nutrition and lifestyle habits. But especially once we have a diagnosis where lifestyle habits can alter the outcomes, absolutely we should be talking about it. Whether it's macular degeneration, diabetes, ocular surface, it doesn't matter what it is. Nutrition is important from the start. What's the best place to find nutrition? Well, it's in food. What is the reality? Well, the reality is if you think that you can change someone's overall general dietary habits, I'm sometimes known to be a little bit cynical, but I would say good luck. If somebody with diabetes goes to a dietitian for intensive dietary education, on average, they change their fruit and vegetable intake by less than 1 serving a day. We're doing a whole eye exam. we may talk some about nutrition and lifestyle, but we don't have as much time to be able to talk as a dietitian or a nutritionist. So my guess is that we're probably less effective. So the best place to get nutrition is in food. The reality is most people don't get enough of the right food. What foods are good for xanthophylls, for carotenoids when we're talking about what we need for macular degeneration? We all know this. Kale and spinach are probably the best. Romaine and broccoli are probably the most common. So I'll mention spinach and kale, but I realize that it's way more likely to get someone to eat some romaine or broccoli if they're not already eating spinach or kale. Now, when I bring up spinach, oftentimes someone says, oh yeah, I get some spinach every day. I put a few leaves in my smoothie. Well, there's probably a bunch of orange juice in your smoothie, and there's probably like 3 leaves, just enough to turn it green, but not enough to give you the lutein that you really need if you want to be preventative for macular degeneration. And so Jeff, you said, don't forget eggs. Well, that's how I know you weren't paying attention, because just 2 minutes ago, I mentioned eggs from Larry Alexander. So I caught you there, buddy. Do you ever ask your patients about fruit and vegetable consumption? And I kind of do this on and off. It's super interesting. Some people say, yeah, I do great. I usually have a banana for breakfast every day. And then there's nothing else. And then there's people that will talk about, well, yeah, I'll usually have some berries in my oatmeal in the morning. And then at lunch, I'll usually have a small salad. And then I'll snack on carrots throughout the day. Then with my protein at dinner, a lot of times I'll have some sort of vegetable with that. I don't know. What's that, 2 or 3 servings? I'm not sure it's very good. No, that's really good. So it's just interesting to ask people to find out, what are you doing and what's your perception about what you're doing? And the reality is what's probably best is a Mediterranean diet. But I can understand if somebody makes an argument for one of the other diets. But there again, not only does an egg a day keep VEGF away, an apple a day keeps AMD away. Again, I love simple solutions. Eat eggs, eat apples, eat more fruits and vegetables. That's fantastic. What about the oxalates and spinach? So yeah, if somebody has kidney stones, then the oxalates may not be good. And so that spinach may not be a good option. They may need to supplement. Are raw carrots a healthy snack? You know, everything is relative, right? Carrots have a lot of sugar in them. So having some carrots is good, but just eating a whole bunch of carrots, you get a lot of sugar and you get a lot of beta carotene, which when it comes to AMD, doesn't do a whole lot. So much better off with spinach, but carrots aren't bad. Oh, here's my slide about the orange juice. 21 times increased risk if you have fruit juice on a daily basis. So in the words of a few of you, no bueno. Is there a best diet? So I would love to see what a few people put in the chat here, and I'll give you my opinion. So is there a best diet? So my answer, if someone says, which is better, Mediterranean or paleo, or if they say vegan or vegetarian, or if they say really anything. Yeah, so I love Michelle's answer. It's one you would do. So my answer, which is better, is yes. And the reason I say yes is whatever you can do and stick to is going to be better than the average American diet. Ideally, it has more fruits and vegetables and lean proteins, and it's more plant-based. But, you know, if someone says, well, it's really not truly a Mediterranean diet, is it okay? Yeah, as long as you stick to it and you're not having a whole bunch of refined carbohydrates, eating ice cream every night. Yes, that's fantastic. So I don't know that we necessarily need to get in the weeds. The best diet is one that somebody pays attention to. Now, that being said, I found this lecture and publication super interesting by Dr. Emily Chu, who was the lead investigator of the AREDS 1 and AREDS 2 studies. And typically she would only talk about using supplements once somebody has intermediate dry AMD. However, in this publication, she talks about the benefits in incident AMD all the way up to late AMD, that there's benefits in the Mediterranean diet. So she says this would suggest it is never too early or too late to adapt a healthy lifestyle such as the Mediterranean diet. I thought this was huge. It's subtle, but huge. Because historically, what Dr. Chu talks about is AREDS 2, the right supplement, intermediate. And this was quite a departure from her normal messaging. And so I think this is really, really important. She also said that genetics seems to affect the efficacy of a Mediterranean diet in people converting to wet AMD. There's a lot of controversy around genetic testing. Again, that's a topic we could go into for at least an hour. I'll mention it on a slide or two. We're not going to spend an hour on it though. What about wine consumption? So people in the Mediterranean drink alcohol moderately and regularly. And as it happens, moderate drinkers outlive non-drinkers. That means 1 or 2 glasses a day with friends and or with food. So we know from studies in blue zones that when you get together with friends and you have a more social lifestyle, people live longer, people live healthier. Kerry Gelb did a great job of showing this in his documentary that he produced, that if you haven't seen it, I think is incredible. But I think it's important to realize that dietary changes aren't all about restrictions. I love pointing out things that are good for you that people like. So if you enjoy wine, that's great. Have a glass of wine. That's fantastic. There are some that may be healthier than others. The bottom line, though, is moderation. So when we say 1 to 2 a day, that doesn't mean you can save up all week and have 14 drinks on Saturday with your best friend. That doesn't work. That's not how things work in blue zones. By the way, if you haven't heard of blue zones, I would encourage you to do just a little bit of research. It's 5 zones around the world where people live longer, healthier, and happier. And it's lifestyle based. So remember earlier when I said that large clinical trials are kind of the foundation for what we do, I think also lifestyle changes should be the foundation of what we do in macular degeneration, along with other things. So there's a comment Dorothy made. It's the Mediterranean lifestyle, not just the diet. And yeah, that's absolutely true. If you spend any time in Europe, specifically along the Mediterranean, people walk everywhere and or take public transportation. You don't see obese people. You rarely see people smoking. The food they eat in restaurants, the portions are much smaller. And so it is a completely different lifestyle. By the way, I love talking about things that are good for your eyes and then good for you. So one of the things we know is that carotenoids are not just for your eyes. Carotenoids help with cognitive health. So we know that carotenoids can help with potentially preventing incident Alzheimer's and all-cause dementia in adults in this country. So yet another reason to start talking about lifestyle, carotenoids in particular, with our patients well before we think about it in especially late macular degeneration. I'm just looking at some of the comments, making sure I'm not missing anything. Okay. Okay, a comment from Max about saffron. Max is really into saffron. So Max, I'm gonna have to do a little bit more reading about saffron because you're making a lot of really good points. And so I would like to learn a little bit about that. So thank you. I appreciate that very much. What's fun about doing these is I get to learn too. So when people are putting comments in, and especially when it's what about, well, that means, hey, why don't you need to go home and read about this so next time you talk, you can address it. So I love these kinds of questions and comments. They make me better, and hopefully that can help me to bring other things. Okay. So lifestyle. So I already mentioned what I talk to patients about. And again, I try to make it super simple. And so let me just give you a few, I guess, ways, excuse me, that I try to make these things simple. So by the way, there's nothing simple about quitting smoking. It's super easy to talk about it. And as it turns out, that's the first step, because 90% of patients with AMD say they were never advised to stop smoking, which is shocking. And less than 50% of smokers know that smoking may contribute to loss of vision. Bottom line is smoking is bad. Everyone should know it. Now, I'll tell you a quick funny story about a patient of mine that when I saw him for the first time, diagnosed him with macular degeneration. And so, like I said, I can smell, we all can, somebody to see if they are a smoker. And this person was obviously a smoker. And so I mentioned, because of this macular degeneration, it's really important for you to consider quitting smoking. And his response, Johnny on the spot, was, hey, doc, what about if when I want to have a cigarette, I just close my eyes and cover them up so the smoke doesn't get into my eyes? Now, my initial thought was, oh my God, what an idiot. Now, hopefully I didn't say that out loud. But then when I thought about it for like 2 seconds, I thought, oh my gosh, brilliance. How did you come up with that? Now, it doesn't work. And I had to tell him why it doesn't work. But that's how hard it is to quit smoking. People are willing to close their eyes and cover their eyes in order to still be able to smoke. There's a comment about resveratrol and reducing AMD. And yeah, there's been Richard did some great research on this. There are some very compelling publications about resveratrol, especially in otherwise non-responders. So I think resveratrol, yet another example of lifestyle modifications. Now, to get enough resveratrol in your diet, you got to drink a lot of wine. You're going to be drunk all the time. So probably need to get it through a supplement. What should I be eating? Well, let me tell you a bad answer. A bad answer is a healthy diet. Why is that a bad answer? Because it doesn't give any direction, right? What does healthy diet mean? Or what does healthier diet mean? Healthier diet may mean, but did you know, by the way, that about a third of people go to a fast food restaurant of Americans go to a fast food establishment on a daily basis? Did you know that? So for those third of people, a healthier diet may mean one less trip a day to McDonald's or one less trip a week to McDonald's, which isn't going to cut it. So we need to be a little bit more specific. So my very short answer is a more Mediterranean diet with more green leafy vegetables, less refined carbohydrates. By the way, alcohol, in particular wine, and chocolate in moderation can be good for you. So a better diet isn't all about prohibitions. It's not all about don't do this that you enjoy. Continue to enjoy, just in moderation. So sometimes that's my hook with patients. Find something that they can kind of get into. So why do I tell my patients you don't need to pump iron or run marathons? Just do something. You'll see the citation there, by the way. That's a quote from the ever quoted Jeffry Gerson, OD. And that's based on the other citation I have on the slide, that if you just walk 1 block a day, you decrease the odds of developing wet AMD by 50%. 1 block a day. Now, don't ask me, is that a block in New York City? I don't know. Is it down the block and Uber back? I don't know. Is it down and back? Is it down, right? So that's kind of 4 blocks. I don't know. It doesn't matter. The idea is it doesn't take much. Just do a little bit. Just try to be active. I never say exercise. I just say try to be active. For some people, exercise is a dirty word. And so I don't want to create that connotation. All right. What vitamin should I take? I just opened Pandora's box, didn't I? I say we could discuss this for an hour, but that's being naive. We could discuss this for several hours. I think what we all need to do is in our mind, have a different strategy or protocol for our patients with no AMD, subclinical or early AMD, and then intermediate AMD. If it's intermediate, study proven AREDS 2 formula, there you go. If it's earlier, then the main thing is something with lutein and zeaxanthin. I would encourage you to use a trusted industry partner that you know that it's what it says it is. And yeah, there's a comment. We could discuss this for several hours over a glass of wine. That would be great. Too bad we can't do that tonight. But the main thing is just do something. More importantly than just do something is just do something to which your patients can adhere, because it doesn't help your patient's journey if you give them some cockamamie plan that they're not going to do or can't do. Make it simple. I would contend that something that's simple, but maybe slightly less efficacious, is way better than something that's completely efficacious that they're not going to do because it's too complex. So just do something. Let me ask you this: do you prescribe vitamins? So if I'm doing a talk, a sponsor talk by one of the companies that make a vitamin, I can't say treatment. I can't say prescribe. Those are medical terms. But when doing a CE like this, I can and do. Because the way that I practice is I treat macular degeneration with, amongst other things, a prescription for vitamins. And if my patient asks me, after I tell them which vitamin to take, if they ask me, so do I need a prescription for that? Then that's a win, because they think it's a prescription and I've created more relevance to it. And so I'll ask. I want to make sure that people understand the importance that it's not just a vitamin. It's a vitamin, and it's a treatment, and it's something that is good for you. Now, by the way, does this image look a little bit blurry? The answer is yes, and that's on purpose. Because if you go to any store and you look at the vitamin aisles, and you look for an eye vitamin, this is what it looks like. It's a blurry mess. There are so many. I know what I'm looking for, and it's a mess, right? Imagine your patient that doesn't know. If all you tell them is, I want you to take a vitamin, an eye vitamin, what are they going to get? Well, they'll probably get the prettiest, or they'll get the cheapest, or they'll look for vitamin I, like ABCDI. There's no vitamin I, by the way. They won't know. They need your guidance. They need to hear it as if it is a prescription. By the way, do you ever just tell a patient with glaucoma, do you write a prescription for glaucoma drop? No. You probably write it for a specific medication. Now, truth be told, it doesn't matter what you write for. They're all getting generic latanoprost. So maybe that's not a good example. But we need to do the same thing here. Be specific, prescribe supplements. Do not make loosey-goosey recommendations. All right, let's talk about multivitamins. Are multivitamins worthwhile? And I think there can be a lot of different arguments for this. What the picture is showing is multivitamins are kind of a fairy dust formulation. And as another tribute to my friend Stuart Richer, Stuart would say that the RDA, so recommended daily allowance, which is what's in most multivitamins, there's basically 100% of the RDA of most things that are in there. RDA stands for ridiculous daily amounts, meaning it's not nearly enough. The vitamin C in a multivitamin is enough to not get scurvy. The vitamin D is enough to not get rickets. They're not enough to have any of the other healthful benefits that those supplements can have. By the way, if someone is taking an AREDS2 supplement, they should be taking a multivitamin. They should be taking both. We learned that from AREDS1, and everyone in AREDS2 was given a multivitamin. Although with multivitamins, we need to be a little careful because multivitamins are fairly unregulated and may or may not be true to the label. So we don't know what people are actually getting, which just kind of reinforces the point that the best place to get nutrition is through food. Now, I mentioned that if someone has intermediate dry AMD, there's, at least I believe, based on the AREDS2 study, an absolute correct supplement that they should be taking for their AMD. And interestingly, if you query your patients with intermediate dry AMD when they first present to your office, and they already knew about the AMD, 43% aren't doing anything from a supplement perspective. 30% are taking a multivitamin or general eye vitamin, and just over a quarter are taking an AREDS2 supplement, which is something that's been proven by an enormous clinical trial done over decades to tell us what to do. These patients are an opportunity. What are your thoughts about AREDS? By the way, so I'm not reading these questions before I read them and try to answer them. So I appreciate nobody sending an absolute curveball to make me look stupid. What are your thoughts about AREDS2 versus eye vitamins from Whole Foods Market for pre-AMD? Of course, other eye vitamins might not have the ingredients in one as AREDS2, but I feel they have cleaner ingredients. You know, I think it's a matter of perspectives. Anyone can say they have cleaner ingredients unless something's been independently tested in an independent lab. You don't know that. I do not use AREDS2 in somebody with subclinical, except for if their spouse has intermediate and their spouse has taken AREDS2 and they're taking 2 a day. For sake of ease, I'll just say, you know what? Why don't you take 1 a day of those? You're taking a half dose. Otherwise, I reserve AREDS2 for intermediate dry AMD. Speaking of AREDS2, what did the abstract from AREDS2 tell us? Does anybody know? It's actually pretty interesting. The abstract from AREDS2 said that primary outcome, switching the supplement, didn't do any good. It wasn't until you further analyzed and you looked at the people that had a diet similar to the average American that you find the benefit. So if you look at the entire population on average, not beneficial. Now, that being said, the population in AREDS2 was said to have a healthier diet than the average American. So if you look at the average American diet, then AREDS2 does help if you have intermediate dry AMD. What about the lack of zeaxanthin in AREDS2? It's a good question. What I would say is we have what we have, right? So we don't know what AREDS2 would have looked like if it would have been double the zeaxanthin. The lutein to zeaxanthin ratio in AREDS2 is based on the ratio of lutein and zeaxanthin in the average American diet, which is crappy and is not based on lutein and zeaxanthin or even mesozeaxanthin found in the maculin. So it was based on poor diet that we get, not what we need. There's a comment that there's zinc in AREDS2, and I would imagine the reason Jeff's bringing that up is because of the potential genetic implications. All right. So if you want to be able to look up the AREDS2 10-year follow-on study, you can scan this QR code. This was published just 2 years ago. And it's pretty cool because it showed that if you look 10 years out, that you basically have the same efficacy as you did at 5 years out. So it shows two things. It shows that 10 years we have both efficacy and continued safety. That's really good. So if we can tell our intermediate dry AMD patients we have something for them that we think will work for 10 years and be safe for 10 years, I would tell you that's a win-win. All right, and so here's just a hazard ratio plot showing that in AREDS2, we continue to see that the addition of lutein and zeaxanthin was beneficial, that adding in fish oil was not statistically significantly beneficial. Neither was lutein plus zeaxanthin plus fish oil. Why is that? Is fish oil bad? Well, maybe, but what's more likely is the wrong ratio of EPA to DHA. Because there was a study that came out, NAT2, in Europe about the same time as AREDS2 that showed fish oil to be beneficial. And what we need to know is there's much more to AREDS2 than just what vitamin to take. AREDS2 looked at, do you see peripheral changes that are related to AMD in your AMD patients? The answer is a clear yes, you do. And that may help us to look more closely at the macula. If we see reticular changes or drusen in the peripheral retina, we can use that as a clue to look more closely at the macula. But another thing that came from AREDS2 was assessing the Amsler grid. Now, I don't know about you, but the way that I would describe the usefulness of an Amsler grid is that it is sometimes better than nothing. There's two questions. What do you recommend for zeaxanthin? We have 7.5 lutein, 7.5 zeaxanthin in Canada. I mean, look, that hasn't been studied to the same extent as what's in AREDS2, so I can't give you the science-based answer. Theoretically, that would be better, I think, but I don't have the science-based answer to that. Also, the question, what about AREDS3? I heard it is being held back until AREDS2 patent expires. Truth? I think not. So I've actually heard of several kind of proposed AREDS3 trials. And the difficulty with any trial, especially in dry AMD, is it's at least a 5-year trial. And if you're looking at earlier patients, which is where the majority of patients are and where there's the potential most gain, then 5 years isn't long enough. You need at least a 10-year study, and that's really expensive. So I think the cost of doing it is why there hasn't been an AREDS2. I don't think it has anything to do with patents. What about mesozeaxanthin? So again, mesozeaxanthin was not in AREDS2, so I cannot talk about it in relation to AREDS2. We know that mesozeaxanthin, when given with the other carotenoids, helps to build macular pigment optical density. So do I have a problem if someone's using mesozeaxanthin? Absolutely not. Okay, so Amsler grid. I think Amsler grid is sometimes better than nothing. It's sometimes worse than nothing because I think most patients do it incorrectly, either through their improper fixation, testing distance, how they do the test or how often they do it, or the cortical completion, or just how subjective it is. I don't really like it. I don't use it with my patients. So unfortunately, what we have in dry AMD is that intermediate AMD oftentimes is undiagnosed. Patients progress between visits. And even if it's diagnosed and they're on an Amsler grid, it has limitations. So oftentimes people have poor visual acuity when their wet AMD is first detected. About 80% of people, their visual acuity is 20/50 or worse at initiation of treatment in the first eye. Why is this important to us? Well, if you look at people being followed for intermediate dry AMD, about 86% are seen by an optometrist or a general ophthalmologist. A fairly small percent, and rightfully so, are seen by a retina specialist. There's really no reason for a retina specialist to be seeing someone with intermediate dry AMD unless you're suspicious that it might be wet. There's a question about astaxanthin and macular degeneration. I think the benefits from astaxanthin, which is another carotenoid, is not in macular degeneration. It's not in posterior segment. It's more in the front of the eye and focusing. So I don't use astaxanthin in macular degeneration. So the reason we need to know about all this is intermediate dry AMD is managed by us. It's not managed by retina specialists. So how can we help our patients with intermediate dry AMD end up with better vision? So what these lines are showing, and Megan basically showed this, is your vision at initiation of treatment is the best we can generally expect after 2 years of treatment. So the sooner we have diagnosis, the sooner we have treatment as far as visual acuity is concerned, the better off people will be. The only people that really gain here are people that start off with horrible vision. So people that start off with horrible vision aren't really seeing much of anything. The improvement they have still leaves them legally blind. So even though some people improve over several years, they're not improving in a visually significant fashion that really alters your patient journey. The best thing is they have good vision when wet AMD is found. So how do we do that? So again, this is showing percentage of patients with good vision at initiation of treatment. And this is across a whole bunch of different studies over the course of several decades. The IRIS registry is probably the most real world and had over 162,000 people in it. And it's saying that only 34% of people were 20/40 or better when they looked at this. So basically what that means is not enough people are diagnosed with wet AMD at an early enough stage when vision is still good. Now, I would ask you, is it important to diagnose wet AMD if someone's vision is 20/20? Yeah, that's the most important because you want to keep 20/20. That's the person that you've got the best chance of having them maintain their lifestyle, continue to drive, read, see pictures of their grandkids. So, we need to have, I think, a deeper understanding of our patient's journey and their emotional journey with macular degeneration. So, we know that people have their life before symptoms, and then oftentimes they start noticing some decrease in vision, which is an annoyance, and it may mean different things as to how their vision has changed. Then they're given a diagnosis, which sometimes brings on anxiety, depression. I'll go over the statistics with that, anger, denial. And then people need to figure out, well, what do I do about this? Do I really need to do something? Do I have to? Can I? And then when they ultimately develop wet AMD, that's their worst fears realized. And part of the problem here is people have a fear and lack of control, especially at diagnosis. So that makes that the most important time for us to have the right in-depth conversations with our patients. And a lot of it's because they ultimately have poor awareness. And so they don't know what the urgency is, what the importance is. And so we need to have a really active part in that to empower our patients. A lot of times we see dry AMD as a low risk, and maybe in the short term it is, but in long term, it's our patients see it as a high risk. So maybe we need to alter our understanding and have it more match the patient's understanding. So if we detect late AMD too late, wet AMD too late, what could that mean? Well, once people have poor vision, then 54% of patients experience a fall. A third have more than one fall. A third of people collide with something, and a third have a laceration from running into something because of poor vision. So you can see where this really affects somebody's quality of life. What about depression and anxiety? I've mentioned this a couple times, and I think this is something that we dramatically under-realize and we dramatically under-address with our patients because it's not comfortable, right? We would all say, well, I'm not a psychiatrist, psychologist, or social worker. That's not what I went to school for. Yeah, but we deal with things that create incredible anxiety and incredible depression for our patients. We know that 40% of AMD patients are affected by depression because of their poor vision. And between 10 and 30% of AMD patients, depending on the study, are affected by anxiety because of their poor vision. Now, there's potentially differences in how poor the vision is. You can make the argument the depression and anxiety is worse when the vision becomes more poor. You could also argue that the anxiety in particular is worse when they still have good vision because they're anxious about losing it. If someone's already lost considerable vision, they may be depressed, but they may no longer be anxious. And I get it. Those are subtleties that are not really for us to define or treat, but something for us to be aware about in our patient's journey. Okay, so you know, if we're trying to look at these OCTs and you have 20/80 vision and a central choroidal vascular membrane, could you do your work? The answer is no. And so we need to think about our patient's vision a little differently. And, you know, and it's not, hey, your vision's 20/50, you're doing great. It's 20/50, and I would imagine you're starting to have some difficulties. What's difficult for you? What may we need to address? Maybe where can I send you to help address those issues? So again, we know that patients who start with poor vision don't catch up. They end up with poor vision. And once they have this poor vision, they're more likely to have injury, depression, anxiety, and they're way more likely to be limited in their driving, their reading, and most importantly, their overall independence. Okay, so Megan mentioned this earlier, and this is something that I use in my clinical practice on virtually a daily basis, the 4C home, or as Dorothy says, the home C4. I don't know what she said. But it uses preferential hyperacuity perimetry that is very, very accurate, and we have level 1 evidence to detect subtle changes that are proven to be significantly sensitive and specific for wet macular degeneration. What's cool about this is it's for our patients with intermediate dry AMD and good enough vision, it's covered by Medicare. And for most people, they don't even have a copay. It costs $0. So for most of my patients, this digital device that they use at home will cost them the same amount as an Amsler grid. The only difference is that it works. So I mentioned AREDS 2 is about more than just what vitamins. So part of the AREDS 2 study was the home study where they looked at standard of care, Amsler grid, or using 4C home. And the way that I like to summarize this study is this. This study was stopped prematurely. Oh boy. So normally if a study is stopped prematurely, it's because what's happening is so bad that it's not ethical to continue subjecting people to the new thing that doesn't work. That wasn't the case here. The case here was that the people that converted to wet AMD that were using 4C home, their diagnosis was so much earlier, was so much better that the study coordinators could not ethically continue to not offer it to patients. So they stopped the study so that anyone could have access to 4C home. And we know that people need to do it at least twice a week to get best results. And what we find is when done the right way, that 94% of patients retain at least 20/40 vision at the time of their wet AMD diagnosis. 94%. That's amazing. That's amazing. That's almost 50% more than people that are just using an Amsler grid. 50% more. So what's 20/40? 20/40 is reading. 20/40 is driving. 20/40 is good quality of life. That's what you can do for your patients. So it's a test they do at home that is remotely monitored, that when there's a statistically significant change, you will be notified to make the decision whether you want your patient to come in or not. Now, you may say, well, Jeff, that was in the AREDS 2 study, and clinical trials always give better results than real life. Yep, you are right. However, what we then see is that if we look at real world data, that the results are almost as good as the AREDS 2 home study. So even in real life, using 4C home is about 50% better than just using an Amsler grid. And remember what I said, they cost your patient about the same. All right. So why is this important? Well, again, if you look at some of the historical studies, you see that across the bottom over the last couple of decades. And what you're seeing is what was the visual acuity at diagnosis of wet AMD and what was the average lesion size. When using 4C home, visual acuity is better than 20/40 and lesion size is 0.23 disc diameters, 0.23 versus the best of any other study. It's about 3 disc diameters in size. Huge difference, huge difference. So we need to catch wet AMD sooner as far as its size, which often then correlates with sooner as far as visual results. The 10-year ALOF study is yet another study that looks at real world using this type of technology. And what it found was that you improve the likelihood of people maintaining functional vision. People have better visual acuity at the start. They have better visual acuity at the time that they convert over to wet AMD. Just in general, people do better. And over a 10-year period of time, people are doing this test on average 5 times a week. I literally had a patient today that asked me, that's doing this at home. He said, is it okay if sometimes I do it more than once a day? I said, well, yeah, it's okay, but why would you do that? You just need to do it at least twice a week. He said, well, sometimes I would just feel better if I'm doing it more often to know everything's okay. I think that's overkill, but that's what this person wants to do, and it works for him. So again, what's important is find something that works. What this is talking about is what used to be termed a false alarm. Now it's called a non-exudative alert. What if somebody sets off a trigger? They've had a change. They come into your office and it's not wet. Thank goodness, that's great. But what we know is if we look 2 years after that false alert, that it's somewhere around double the likelihood that they will convert to wet AMD. So if someone has a false alert, then we need to watch them more closely. They need to be testing more vigilantly. So even a false alarm gives us really important information. As I said, way better than an AMSR grid. So like I said, I virtually never use an AMSR grid. I'll even tell people to stop using them, even if they're not using F.A.A.O home. What I'll tell them to do is I'll ask them, where do you read news? Do you get a newspaper? Do you read it online? Whatever you do on a daily basis, what I want you to do is cover one eye, then cover the other. And if it changes over time, let me know. Because they're probably sitting at the same computer, same distance, same font. I think that's better and easier to do than an AMSR grid. All right, so can or should there be other or better vision testing apps? And so this is a publication just from this month, and it looked at 3 readily available vision testing apps. 2 of them are actually apps, one's on paper. It compared all 3 of them as far as will it help detect conversion to wet AMD sooner than just going in for exams? And the answer was no, none of these helped. So if you say, well, gosh, are there other apps available that my patient can find? Are there other things you can do? Sure. There's other things you can do. They just don't work. Again, AMSR grids from the 1940s, just like this car. That car's cool, but I'd rather be driving something a little bit more modern. The same company, by the way, that makes F.A.A.O home makes something called Scanly. Now, I'm not going to ask how many of you don't have an OCT in your office, but I will tell you that now your patients with wet AMD could have an OCT in their house. You heard it. FDA approved for monitoring wet AMD in the home. Same technology as what you use in your office. Think of it as treat and extend, but on a personalized basis. So it looks like this. It's been studied in thousands of people in the US. And basically what it does, it plots over time whether there's any fluid, and the treating physician can put in the algorithm. Once there's X amount of area of fluid, then set an alarm. And that's how I know I need to have this patient come in for their next injection. Maybe they go 12 weeks and they're completely dry. Maybe they go 16, maybe they go 24. And we wouldn't know it if you're not testing at home on a routine basis. So what this is going to do, there will certainly be patients that this decreases burden, that they go longer in between because they don't need injections. There'll be other patients that it increases the burden, that it causes them to need injections more frequently. However, they will therefore have better outcomes. So it's need-based burden is what I would call it. And that's what this means for our patients. I think this improves the overall experience by creating a more personalized plan for return visits and or treatments. It can create peace of mind for patients knowing that they're not being undertreated or being overtreated. And it's like having a high-tech exam in your office several times a week that's being done at their home, being looked at by the monitoring center and their treating physician. There was a question earlier about genetic testing. This is another area I think that is a means of personalized care. And just like everything else for this talk, I wanted to address this from the perspective of patient experience. So instead of talking about what this means for you, the practitioner, I wanted to talk about what I think this could mean for your patient instead. So can this improve the patient experience? I think so. Could it make the patient experience worse? It's possible if it's not done judiciously. So I was doing a patient seminar this last weekend, and I had a patient come up to me that had been to one of the patient seminars I had done a year ago. And she said, I just want to thank you. After I heard you last year, I went out and looked up one of the two companies you told me about, and I did genetic testing for my AMD, and it showed I was at really low risk. And I felt so much better about it because of that. And so that was really kind of rewarding for me to hear that in a real life patient. Now, what about if you find out that you have higher risk? Well, yeah, that could create anxiety if we don't talk about it appropriately and explain, well, because you're higher risk, maybe we'll see you in the office more often. Maybe we'll have you doing this at-home digital monitoring. Maybe we'll be a little bit more adamant about some of our lifestyle modifications that we make. But really, the unknown is often the greatest source of anxiety. And so oftentimes just knowing, good or bad, can bring on a sense of calm and knowing. There are two companies that have patient pay model. There used to be one that did a insurance pay. They no longer do insurance pay. It is patient pay only. I think there's definitely no doubt, no argument that genetic testing is beneficial for helping to determine someone's risk of progression to wet. What is very contentious, and again, I'm not going to open this can of worms, is whether genetic testing will tell you whether you should be on a supplement with zinc or not. I can make a compelling case either way, that genetics tells you whether you should be on a supplement with zinc, and that certain people zinc is the worst thing. I can make a compelling argument that everyone should be on the same AREDS2 supplement regardless of genetics with the same zinc, because there's conflicting studies. I would encourage you to look it up. You can look up papers by Carl O. You can look up papers by Emily Chu. And there's Johanna Seddon has written about this. And there's other authors as well. There's a question, do you see any use for F.A.A.O and Scanly in GA patients? The answer is no. So Scanly is for detecting changes in fluid. So really so Scanly has no place in GA. It's for once people already have fluid and are being treated for it. F.A.A.O potentially could, as long as the GA patient has good enough vision. But theoretically, it's only FDA approved for intermediate dry AMD with good enough vision. So I don't use it in my GA patients. What are the two companies you recommend? So there's actually only two companies that have genetic testing. One is, the test name is Macular Risk by Arctic DX. And the other company's name is Visible Genomics. Does 23andMe count? No, because it's not very specific. Let's talk for a minute about GA. GA obviously is an advanced form of AMD that affects about 1 million people in the US. After age 50, the prevalence quadruples every 10 years. It accounts for about 20% of legal blindness. And what I would tell you, the most important thing to know about GA is it does not progress nearly as slowly as what you think. So I think of glaucoma as being a slowly progressive disease, and historically, I thought the same thing about geographic atrophy. That is just not true. And we found some of this out through some of the studies for new treatments for GA, because for these new treatments, the control was placebo because there was nothing approved. So that means we have natural history. So you can see these three statistics here, that 16% of GA patients progress to blindness in the better seeing eye with a median time of 6.2 years. 2/3 progressed to vision loss that left them unable to drive in 1.5 years. 40% lost at least 2 lines of visual acuity in 2.5 years. So that's saying that in 2.5 years, that more than half of people will lose the ability to drive and lose at least 2 lines of visual acuity in just 2 years, or slightly over 2 years. That's pretty quick. And so that's why we need to do our best to prevent GA. And then if someone has it, to consider sending them for treatment. So as I said, GA is treatable. The studies show that there's actually just a 3 result study. So I need to actually update here. They get up to a 30% or maybe slightly more decrease in lesion growth on average, which means lesions are growing, just not as quickly. Now, they also slightly increase the likelihood of choroidal neovascular membrane, to which a retina specialist would say, no big deal, because I can treat that. I don't know if you want to trade one bad thing for another, but something to think about. Is it for everybody? I'll tell you that many retina specialists are not treating GA. One is the fear of the burden on their practice. And two, when they treat wet AMD, if you treat a choroidal neovascular membrane and the patient comes back 3, 4, 5 days later, you will see a dramatic improvement in most cases. If you treat people for GA and you have them back in a week, a month, or a year, they're not better. They're worse. So there is no instant gratification. And so this has not been adopted quite as quickly as I think many people would have expected. And patients need to know that as well, that the expectation can't be go get this treatment and you'll be better. It's go get this treatment and you'll likely not be as much worse 2 or 3 years later. And here you see again that the difference between sham and treatment, this is with Syfovre, continues to increase over 2 years. And the 3-year data shows that it increases even more. This is for Izervay. And again, this is showing 18 months. And again, showing that as time goes on, the two lines diverge even more. And at 2 years, it is more than 30% difference between treatment and sham. This may be my favorite question of the day. Can light help macular degeneration? Let me go to the chat. At what point do you refer for GA treatment? That is a trick question. Because number one, you have to have a retina specialist that's treating it. So that's step one. You have to find out. Step two, you need to talk to your patient to see if they're willing to undergo treatment, because there are intravitreal injections every 1 to 2 months to slow down the worsening of their vision. So what I've tended to hear from most retina specialists and colleagues talking to retina specialists is kind of what seems to be happening is retina specialists, if a patient has 2 good eyes, they're not treating GA. Once they lose vision in one, they're treating the other. Now, I don't get it, right? That's like saying you have glaucoma. Let's wait for you to lose your fixation in one eye, and then we'll start treating the other to see if we can save it. It sounds kind of crazy to me, but that's just real world and what's really happening. All right, can light help AMD? So photobiomodulation, using light to modulate biology. And so there's a company that has a device, you see it here, not yet approved in the United States, but approved in Europe and Australia, that has been shown in people with intermediate dry AMD to decrease the likelihood of progressing to GA, to improve vision at 13 months by a line, which to me is amazing, because I would tell you most of my intermediate dry AMD patients are seeing 20/20 or 20/25. So on average, with all comers, to improve vision by just over a line, that's amazing. It is a light. So 3 different wavelengths of light shine into a person's eye, one eye, then the other. The treatment takes 5 to 10 minutes. The difficulty is it's 3 times a week for 3 weeks, 3 times a year. So there is some burden there, but the treatments are fairly quick. There's no injections, so it's fairly easy to go through. So this is just a plot showing the primary visual efficacy at 1 year. And then we see that that is maintained out to 2 years. So we can improve vision. We can decrease the likelihood of it getting worse. To me, this is super exciting. Again, because it's a light. So this is something that we should be able to have in our offices for our patients. I think it's pretty cool. All right. So to conclude, I always talk about this. I always end my AMD talks with this topic. So we've all had patients that go to the retina specialist and they ask what else can be done. And the retina specialist says, I'm sorry, nothing else can be done. And the correct statement may in fact be nothing else can be done medically. However, have you heard of low vision? And unfortunately, there aren't many of us that do low vision in our offices, but for those that do, it can be incredibly rewarding for you as a practitioner, but more importantly for your patient along their journey can be incredibly beneficial. So I would just remind you that just because you don't do low vision doesn't mean that your patients don't need it. Please, 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 if you have patients with AMD in your community, find someone that does low vision. You can consider doing it on a small scale yourself, but find someone that does it because you have patients that need it. And I want to end with a shameless pitch. I earlier mentioned the Macular Degeneration Association is a nonprofit organization that I work really closely with that I think has a really good website with lots of great information. And there's a in the news section of it where there's new stuff posted like every day or two, something new. And it is a great resource for patients. It gives them hope, kind of like it's in the name. There's webinars that get done. There's like 10 or 12 webinars a year. We do in-person patient seminars. So depending on where somebody lives, they can go to an in-person one. It's just a great resource. And I think this partially allows me not to have to do quite as much education or as many handouts, because this is a great resource. They also have handouts that I have that I give to patients as well. So just a great resource for you. Now I see we have a couple questions in the Q&A. So I want to address those. Okay, I already got that one. Do you recommend macular pigment optical density testing for a more personalized care? And how do you explain the relationship between MPOD and progression of AMD to the patients in simple language? Good question. So I do some macular pigment optical density testing because it is a risk factor for macular degeneration. I don't know that I can tell someone an absolute number that if your MPOD is this, your likelihood of macular degeneration is that. What I can tell them is as we supplement, if you have low MPOD and we supplement you and it improves your MPOD, that will decrease your risk. Just as importantly, it will improve the quality of your vision. So I actually don't hang my hat on the decreased risk. I hang my hat on quality of vision, whether that means contrast, which improving MPOD has been shown to improve, visual acuity, which has been shown to improve, light sensitivity, shape discrimination. All these things are shown to improve with improved macular pigment optical density. So it is certainly not a one-trick pony. What frequencies are used in the PDM study? Is it an LED or laser? So it's a good question. And I actually forget the actual wavelengths. It's an LED, not a laser. And the frame of reference that I'll give you is that if you know anything about how our colleagues in the UK and Australia practice, their scope is dramatically more limited than ours, and they're doing this. So not that that means we'll be able to, but I think just that perspective tells me that it's pretty likely that this is something that we will be doing because of their limitations and their ability to do it. One of the answers was 670 nanometers, but there's 3. So if that's correct, I don't know what the other 2 are. All right, any more questions? I've found that B&L's Sight Matters website is very helpful to patients with AMD. I totally agree. So any patient that I have start or that I know is on AREDS 2, I give them a handout or an AREDS 2 sample, and I tell them the sample is almost meaningless. It's a day's worth. The reason I'm giving the sample is in the little brochure in here, you unfold it, it gives either a phone number to call or a website to go to sign up for Sight Matters. And like macularhope.org, it has lots of great information. Plus, they'll send people more coupons than they could ever use. So patients love that. All right, so by my timer, so I always start a timer, by the way, when I do a talk, I'm at 1:40 on the dot. So that's our 2-hour requirement. So I think we're good, Dorothy.
Yeah, great. Thank you so much. If everyone could just stay on for just a moment, I will give you some quick instructions on how to earn your CE certificates, and we'll wrap the evening up. So thanks to Dr. Gerson. Thank you for being with us. Great lecture. I actually was listening. I was doing a little cheaty multitasking, but it's always wonderful to hear someone else talk on this subject. I always learn something, just like you learned stuff from our mentors, Larry and Stu, who I'm sure everybody misses. So thank you so much for the talk. For the audience, please remember you'll receive an email, a Zoom email with instructions for receiving your certificate. It really helps us if you fill out the survey that comes along with the instructions, helps us plan for future webinars, and it also facilitates your certificate. So again, thank you for joining us tonight, and live well, be well, and we'll see you at the next webinar. Thank you so much.
Thanks for having me.
Yes.